Good evening and welcome to tonight's dermatology webinar. Thank you to everyone for joining us. For those of you that don't know me, I'm Lydia Morgan, one of the commercial managers here at VVS. Tonight, I will be introducing our fantastic speaker for the evening, Dr. Rosario Cerundolo, with his enlightening presentation on the management of atopic dermatitis in dogs. For those of you who are meeting virtual veterinary specialists for the first time, welcome, and we really hope you enjoy tonight's webinar. VVS is a team of friendly, knowledgeable and supportive veterinary specialists. Their mission, along with all of us working at VVS, is to improve access to specialist veterinary healthcare for your patients and to increase collaboration between first opinion vets and specialists in clinical practice. With our sophisticated video sharing and diagnostic platform, we empower first opinion vets to work in real time with our specialists and continue to care for their own patients in their own practice. Our goal is for you to see our specialists as an extension of your clinical team. We're on hand to support you, your patients and their owners with affordable and timely help. Services we offer include specialist-led, live-guided clinical workups, like our full cardiac consultation and echo, our abdominal ultrasound, and our neurology examinations. We can also assist promptly with specialist advice calls available at a time that suits you in any of our 11 veterinary disciplines, including our brilliant dermatology service. With our written ECG reports, bespoke chemotherapy protocols, and radiology reports, amongst many other written report offerings, our aim is to share specialist level knowledge and to support your veterinary team. We're now pleased to offer the VVS Holter service for 24, 48-hour and 7-day Holter monitoring. A Holter monitor is delivered straight to your practice. Following recording, you receive support from the VVS cardiology team with ongoing management and advice to accompany your report. For any information on any of these services, please feel free to scan the QR codes and they should take you to our website for more information. It's now my pleasure to introduce Dr. Rosario Cerundolo, European and RCVS specialist in veterinary dermatology. Rosario graduated from Naples Veterinary School and then started a residency at the Royal Veterinary College. In 1998, he gained the European Diploma in Veterinary Dermatology, and in 2000, he became an RCVS specialist. Until 2009, he was Associate Professor in Veterinary Dermatology at the University of Pennsylvania. He's Honorary Associate Professor of Veterinary Dermatology at the University of Nottingham. He's been the former President of the European College of Veterinary Dermatology and the Chair of the Scientific Organizing Committee for 2 of their past annual Congress. In 2020, Rosario was granted the Fellowship title of the RCVS. We're therefore incredibly lucky to have Rosario with his extensive wealth of experience presenting for us this evening. If you have any questions as we go through the webinar, please add them to the chat box and we will finish with the presentation with a question and answer session. So without further ado, I'll hand over to Rosario and we hope you enjoy tonight's webinar. Thank you.
Thank you very much, Lydia. I hope everyone can hear me well. And good evening to everyone. Let's get started. Just 1 second. Okay, so Lydia has already kindly introduced me. So tonight we are going to talk about the management of atopic dermatitis. But before we discuss how to manage atopic dogs, I think I really would like you to be familiar with the workup that is needed before we get to a diagnosis of atopic dermatitis. So how do you diagnose atopic dermatitis? Well, you can suspect atopic dermatitis if you have a patient like a dog that is licking, chewing, biting, scratching, shaking, twitching, and rubbing. Or if the dog has also got otitis, which can be unilateral, can be bilateral, and there are different degrees of severity of otitis. But before we get to the point that we can say, yes, this patient has likely got atopic dermatitis, I just wanted to spend 2 slides to tell you the workup that is needed, because I see so often. Can anyone hear me? Because Sarah said that she can't hear. Lydia, can you hear me? Okay, so looks like that everyone else can hear me. Okay, so the workup that is needed, is to rule out parasites. You will not believe how often, okay, great, that other people can hear me. You can't believe how often I get patients that have been treated with all sorts of medication. At the trial of APOQUEL, had a few injections of cytopoint. They were wondering if to start cyclosporin. And this patient had just scabies or demodicosis. Fleas is something that I rarely see probably at the level I work, but time to time, fleas are also there, especially in cats. But then if I don't find any parasites, or if you don't find any parasites, the next step and the next question will be, has this patient got a bacterial or yeast infection? And then you need to address that type of infection. Nowadays, most of the time we are using just antiseptic topically that are enough. We rarely use antibiotic. And then if you have dealt with the infection, then you still need to consider the possibility of a flea problem. And then if you are 100% sure that flea are not around in any of the pets that are in the house, then the next step will be to consider the food allergy possibility. Food allergy is still common, and many people will probably underestimate the frequency and the prevalence of the food allergy. But you need to make sure that you have ruled out food allergy first before you can make a diagnosis of atopic dermatitis and discuss the options. I mean, there are so many of you tonight, and I'm really happy that there are so many participants. And I guess probably because the topic, it's a very hot topic. And it is indeed, because when you look at what the insurance get as claim in the US and also here in the UK, allergy is the top one, and has been the top one for many years in the States and even here in the UK. The Kennel Club, with whom I'm in contact for several projects, they recently told me that currently the Labrador are the top breed for hypersensitivity skin disorder when they get a claim. And then, of course, includes atopy and probably other type of allergies. And then even otitis is one of the top 10. You may be aware probably of this paper that was published last year, written by UK colleagues about the prevalence of the most common condition reported in UK veterinary practice. And probably your practice was one of them that has collaborated, and definitely skin and ear problem are the most common. Okay, so we get to the point how we treat atopic dermatitis. And I'm sure many times clients will say, okay, now we have a diagnosis, how do we treat? Well, believe or not, the first things that I tell to the client when I get to that point is, there is no cure. So people are prepared. So they know that I've not got holy water, or I've not got a magic solution to treat the dog and then we'll be fine after 2 weeks, 3 weeks, 3 months. Because people often say, okay, for how long, and then we'll be fine. No, forever. Your patient needs to be treated forever, because it will be very unlikely that the patient will not need therapy anymore. So that's the first things that I tell to clients. So they are prepared that they need to commit to treat that pet for the rest of the pet's life. And then the reason is because we can only control the clinical signs. We can't really cure the mechanisms that are involved, although nowadays, fortunately, we are lucky because there are drugs that can help us to manipulate the immune response. But definitely, there is nothing that can cure forever the condition. I'm sure many of you were emailed this type of question because I was asked to provide a question that would somehow probably stimulate you to do some type of thinking. And I'm sure you have been facing this situation many times. 10-year-old chocolate Labrador, and you will see later why chocolate Labrador, with pruritic dermatitis. And so what are you going to use? What are you going to do? Based on what I've told you so far, I hope that you will do the workup properly, and then you will consider one of these options. But these are not the only options available. There are many other options that we need to do. And now I created some type of scenario. And I really would like you to think about while I finish my presentation about these next 5 or 6 slides. So one possible case is a 7-year-old German Shepherd, long history of well-controlled atopic dermatitis, whatever they are using. But the most important problem is that recently there has been a diagnosis of MRSP or MRSA, deep pyoderma. So probably you are in control of the pyoderma. You have decided what to do with the pyoderma. But what about the underlying allergy? How are you going to manage the allergy for another probably 7 or even more years? So think about this possible case. At the end, I'll give you my answer, or at least how I would approach this case. What about a 12-year-old Westie with a long history of almost well-controlled atopic dermatitis, but unfortunately recently diagnosed with cutaneous lymphoma? So probably you know what to do very well for the lymphoma, but what about the atopic dermatitis? How are you going to control? What are you going to choose? Something that perhaps may be controlling the lymphoma and the atopic dermatitis, so this patient needs 2 different types of medication, or probably multiple types of medication. And have you ever been presented with an English setter, young, 4 years old, with a very long history of atopic dermatitis, which was confirmed, and then has been very well controlled with cyclosporin? But then this patient needs the annual booster and can't stay without cyclosporin because it becomes itchy again. So what are you going to do for 2 weeks? Well, for 4 weeks, because you are going to stop cyclosporin 2 weeks before and 2 weeks after. So which will be your ideal approach for this patient with a very pruritic atopic dermatitis? And what about those horrible cases of English bulldog that come with a long history of atopic dermatitis because everything else has already been ruled out, but they've got the pododermatitis, this interdigital furunculosis, the hyperproliferation of the interdigital skin. And many of you would probably like to check for foreign body, which is something that I see is done all the time, even in the middle of the winter, and I always wonder why. Anyway, and then you plan probably to start on a systemic antibiotic, topical therapy. But the problem is the underlying cause. How are you going to address the atopic dermatitis in this patient so will not have pododermatitis anymore, or at least the pododermatitis will be controlled? And then what about those Cocker Spaniel that come with a long history of bilateral otitis because they have an underlying atopic dermatitis? What are you planning to do? Perhaps CT scan because it's a chronic otitis. You are worried about otitis media. You are considering suggesting an ear flush, topical therapy. But the problem is controlling the underlying cause, the atopic dermatitis. I see so many times, almost every day, dogs that have been through a collection of otic medication, all the ones that are available on the market, and the otitis is still there. Because the question is that the underlying cause has not been addressed, and the dog will have ear problem forever. And the client feels that probably otitis is improving, but it's just the steroid that is in the otic medication that is probably giving some dogs some relief and looks like that the infection is resolving. But it's not, because it's still there in the horizontal ear canal. So that's the reason why there is a kind of workup, quite sometimes complicated, because CT scan, ear flush, videotoscopy is expensive, requires general anesthesia, but honestly it's needed. And then, of course, what type of approach are you going to have for this patient with atopic dermatitis? And then what about those puppies or young dogs, like this young Jack Russell, with a very long history of pruritus, not responsive to a diet control or a strict ectoparasite treatment? So you may probably suggest to keep on a strict flea control. You may want probably to suggest to keep on a strict diet. But then, how are you going to treat this 9 months old Jack Russell? It's too young for some medication, or it's old enough for some medication? And what about the long-term treatment for this patient? Do you want to use something safe, easy for the owner to apply or to give? Well, I think I've given you probably plenty of possible scenario to think about. And but don't worry, I'll give you the answer at the end of my presentation. So that's one more reason to stick with me until the end and don't fall asleep. And although I'm sure you probably feel hungry this time of the day. But anyway, the most common question that I get by the client is, okay, for how long should I treat it? And I always tell them, look, it's not a one-off treatment. It needs to be regularly assessed, at least every 3 or 6 months, that I would normally recommend. And then perhaps the treatment may be changed, modified, because atopic dermatitis may be an evolving condition. It's not static. The plan may change, and it's very common. Dogs may have flare-up, and they may have a bacterial infection on the skin, bacterial infection in the ear. Because unfortunately, this atopic dermatitis presents with skin problem, ear problem, and I often see cases that come through the medicine or the ophthalmology department where they have rhinitis, conjunctivitis, similar to the hay fever symptom that are seen in people. So it's not just the clinical signs, but it's also the age and the stage of the condition. So these are 3 different Westie. It's not the same Westie that I took picture and waiting for the dog to get worse and worse. These are 3 different dogs. But can they be treated with exactly the same protocol? Topical therapy, systemic therapy? Or would you consider 3 different, perhaps, approach for these dogs? Well, it's very likely that the first one may be treated in a slightly different way because the clinical signs are probably mild. But in this case, there are chronic changes affecting the skin. So definitely there is a need for a more complicated approach in this case. And then I always discuss with the client, if I've done allergy tests, that avoiding the allergens is something important. But how do you avoid the contact with the house dust mites, for example? I always make a joke and say, okay, are you planning to move to the North Pole? That is going to help. But not many people are probably willing to do that or let the dog to live outside in a kennel because they are pets. They stay in the house. They are constantly in contact with the carpet, the rugs, the bedrooms, which are probably full of house dust mites. An interesting study was published by Stephen Shaw and a group of other people from Nottingham, where they looked at thousands of dogs. And they found that, interestingly, the risk factor that will lead to atopic dermatitis are living in urban environment, being male, neutered, receiving flea control, being allowed on furniture like sofa and fabric chairs. And then protective factor include, for example, living with other dogs, walking in the wood, fields and bees. So being exposed to the outside world more than dogs that are probably confined to the home environment. And then chocolate Labrador, that's the reason why I made that comment, are definitely the ones that are more prone to allergy compared to black or yellow Labrador. Ectoparasite control, whatever you are going to use, that's fine. Then depends, of course, if the dog is on a food trial or not. You may want to switch to the spot on rather than the tablet. And then, as I mentioned at the beginning, infection, it's something that unfortunately may still be causing problem because even dogs, sometimes that are well controlled, they can have flare-up. And so they can have skin infection. And honestly, nowadays, we rarely use antibiotic, at least in dermatology. And I'm sure you have heard about probably other services that are limiting the abuse of antibiotic. It has been done by the previous generation of vets and MD. So what I will normally recommend, assuming that the people, the owner are able to give a shampoo and is not, I don't know, a Newfoundland, that of course is going to be difficult to shampoo twice a week. But there have been studies that have been published, and this study was published in a journal called Veterinary Dermatology. I'm not sure if you're aware about this journal, but published all the article related to dermatology, showed that the combination of a 4% chlorhexidine shampoo and solution is as effective as 4 weeks of antibiotics. which means that we are using antiseptic and we are resolving the pyoderma. And that's what the conclusion of the study suggested. And then don't forget those dogs with atopic dermatitis that have the pododermatitis, like the English bulldog that I mentioned to you before, or those cocker spaniel with otitis and all the other breed that develop otitis. I mean, you need to treat this dog with antibiotic, with steroid cream. Always make sure that the antibiotic is not flavored, because that's a common mistake, that dogs that are on a food trial, they get a flavored antibiotic or flavored painkiller that screw up completely the food trial. And then make sure that the ear problem are also treated properly, addressing the ear, doing an ear flush if it's needed, otoscopy, diagnostic imaging test if there is any concern about otitis media. So it's so important to deal with the infection, because unfortunately bacteria will produce a lot of inflammatory substances that will cause epidermal damage and break down the skin barrier. And why the skin barrier is so important, I'll come back to that in a minute. So topical therapy is definitely made a huge difference, since we have been using a good product that are able to control the microbial population, the yeast population, and also renormalizing the skin barrier. So sometimes it's also the only therapy that it's given in dogs with horrible skin, like the Westie with the black and hyperlichenified skin. Of course, we can also do something or recommend something to the client to prevent infection, because the dog may be completely healthy, but we know that probably in a couple of months there will be plenty of pollens around, and then eventually they will start licking the paw, having facial fold problem, especially in those breeds like Boston Terrier, English Bulldog. So we want to make sure that they clean the paw when the dogs come back from a walk. It's so important, because cleaning the paws, and I really love the wipes because they not only remove the dirt, the pollens, but they also disinfect and kill bacteria and yeast. So that's something which must be a routine. I always tell to the client, look, needs to be done each time the dogs come back home, because if there are pollens among the digits in the interdigital skin, the dog will start leaking, and then the more the dog leaks, the more the microbial population increase. So it's a vicious cycle that we need to stop, keeping the paws clean all the time. So seborrhea, so there is a need for anti-seborrhoic shampoo and for scaling, because some dogs, funny enough, have scaling and some dogs have seborrhea. Difficult to explain why, but that's Mother Nature has made some dogs more greasy and some dogs more having dry skin and a lot of dandruff. And here again, we need to moisturize the skin. I mean, this time of the year, if you have dry skin, dry hands, what you do? You moisturize your hands. If you have used a lot of EB scrub in your practice, at the end of the day, your hands are very, very dry and cracking and painful. So you're applying a cream. Aveeno is my favorite. And then something needs to be done also in dogs with dry skin and scaling. And that's the reason why, fortunately, there was a study that was published 2 years ago that showed how moisturizing the skin, restoring the barrier at the level of the skin, is definitely an important part in controlling the inflammatory response that occur at the level of the skin in atopic dermatitis. How do we modulate the cutaneous microbiome? Because you know that the more the skin is damaged, the more the microbiome is abnormal or altered. So there have been so many studies published. Lactobacillus is something similar. Probably you have been drinking this morning for breakfast in your Yakult, or probably whichever yogurt you have been drinking. Well, this was a study from Japan where they found that there was improvement in the group of dogs that was treated with the oral administration of lactobacillus. Fortunately, in the UK, we have a product that became currently available that is so formulated as a spray. And this was studied by the dermatologists at the University of Florida, where they found that spraying this product daily has helped controlling the clinical signs associated with atopic dermatitis, as you can see in the conclusion here. There is also a tablet formulation available, but no study have been done so far, but seems to be also a promising product. And then what about the skin barrier? Why this needs to be repaired? Because unfortunately, imagine the wall that is around your house or your property. If the cement in between the bricks start to crumble and fall off, then eventually the bricks will probably be detached from each other, and then the walls may fall off. And that's what happened in the skin. The cement that is in between the keratinocytes is going to lead the bacteria and pollens to become in contact with the antigen presenting cells that are at the level of the skin, and then it will trigger the immune response. So we need to restore the epidermal barrier. We need to make sure that there is a nice barrier that stops germs and pollens to trigger that inflammatory response. And there are so many factors that are involved, like the filaggrin, the ceramides. The reason why I'm mentioning this too is because there are so many products on the market, fortunately, that are available on the UK market, either spot on or spray or foam or whatever, which are very helpful. And I'm sure probably you are familiar with Allerderm, which is an excellent product because it's a blend of ceramides, which is going to repoint the cement that is missing in between the bricks. The same is also with the phytosphingosine, which is also a natural component of the skin. And so application of this product help again. Now, of course, you may want to choose one or two of these products. You don't need to use all of them. And then the Dermoscent, which is one of the French cosmetic company. And as the women know, French cosmetic products are probably the best on the market. They came up with this product, which is a mixture, as you can see, of herbal product, which is very helpful also in controlling and restoring the epidermal barrier. They even come up with a new recent product, which it's even better than the Essential 6. So we have plenty of this product. And more recently, there was also another one, the Dermal Ease, that again, study from colleague from the University of Barcelona in Spain showed the great advantage of this product. So all of them will be helpful. I normally probably get just a couple of them that will ask the owner to alternate every week. Now, we need to discuss about the therapy in this patient. And so, as you know, we have many options. And then the option have also cost, possible side effects. So I always tell the client, these are the options. I tell them the pros and cons, and then I let them to decide what they would like. So we have the allergy vaccine, the antihistamine, the corticosteroids, cyclosporin or topical tacrolimus, essential fatty acids, oclacitinib, and LOKIVETMAB. So how do you choose which one to use? Based on what the rep has recently told you, that one product is more effective than the other? Preference? Cost? Well, there is a logic behind which one to use, and you need to follow what I suggest in my next slide if you want to better approach this patient. So what you need to do is to use product that will induce disease control. These are patients that are uncomfortable, have been driving probably the owner crazy because the dogs are itchy, they are not sleeping during the night. So you need to give something that will give the patient some relief. So steroids systemically, or oclacitinib, or LOKIVETMAB. And then once the main clinical signs are under control, then you can discuss with the client the next step. The next step could be the allergy vaccine, the antihistamine, the cyclosporin or tacrolimus, corticosteroids used probably topically, maybe just enough, adding essential fatty acids, and all the epidermal barrier helper that we have been discussing in the previous few minutes. So you are probably familiar with all of them, but I just want to briefly go through them and point some important fact about each one of them. So steroids. PrED is probably one of my favorite because it's very effective, but unfortunately there are short and long-term side effects. And probably all of you have experienced client coming back and say, oh, my dog is drinking, urinating more, mood changes, blood abnormality, polyuria, bladder infection, thinning of the coat, hair loss, and so on. And so unfortunately, there are a number of patients that are not really suitable to long-term use of steroids. And also because long-term would eventually induce calcinosis cutis, which is going to be another nightmare because all the calcium absorbed in the skin is going to take ages to be reabsorbed. And then there are secondary bacterial infections, which are also a nightmare. So that's a very good option, but we need to keep in mind all the cons about steroids. And then APOQUEL. When APOQUEL came on the market, it was such a relief for many of us because it has been making the life of many pets, which was so miserable, suddenly changed, and dogs were so much more comfortable. So adverse effects are really very, very few and not very common at all. So not much concern about this. I just want to tell you the story about Robbie and Jack. Robbie and Jack are two Westies. They were brothers. And Robbie came to see me in January 2014, and he had this type of clinical signs. The erythema, the hyperpigmentation, the scaling, quite severe in the inguinal area, on the inner thigh. You can see the seborrheic material on the skin. And then the dog was very uncomfortable. And this is the same dog as you can see after starting on APOQUEL. So only, sorry, the next slide, only 1 month after, from January to February, you can see the dog's skin is much improved. The inguinal area is definitely much better. And this is the dog before and after. So after only 1 month, we can see that the medication has reverted some of the changes like the lichenification, the hyperpigmentation, the erythema. But then more interestingly, 2 years later, the owner came back because the other dog had started to develop clinical signs. And you may wonder, okay, why two brothers living in the same environment, same food, one has developed signs 2 years before and the other one later? No explanation for that, but that's what happened. I always like to ask the question if the owner know about what the other littermates are doing, because it's interesting to know that sometimes there are other pets that are showing clinical signs, or they've already shown clinical signs, or perhaps they may be showing clinical signs later. So this dog had similar clinical signs: cheilitis, the dry skin around the lips, quite severe hyperpigmentation in the ventral part of the body. And this is the dog, as you can see, June, July, September, 2 months later, much better after being on APOQUEL. And this is the ventral neck Cocker Spaniel. Only 4 weeks on medication with APOQUEL has made a big difference. And this is the interdigital skin of another patient. So great product. LOKIVETMAB. This came more recently, is also a very good product, licensed for atopic dermatitis, for allergic dermatitis. Very rarely patient will probably be vomiting or having lethargy. It's great because it can be combined with other therapy, like, I don't know, the allergy vaccine, the APOQUEL, the CICLOSPORIN, the steroids. There have been a number of studies that have shown the efficacy of this product. In America, they use a much higher dose because the injection is supposed to be given every 2 months. But here in the UK and in Europe, it's given every month. But I found that some dogs may need every 3 weeks, some dogs may need every 5 weeks. So difficult to predict. It's not really mathematic that is going to last for weeks. The mechanism of action, and you have probably seen this in all the brochure that were left to you by the rep of the company, so I don't need to spend time on this. There was an interesting study done by the dermatologists from the University of Florida, where they found that they compared, as you can see, oclacitinib, cyclosporin, lokivetmab, and prednisolone or no treatment in atopic beagle dogs, because over there is a colony of beagle dog that is purposely used for research. They found that lokivetmab prevented the flare-ups before challenging them with house dust mites. And then oclacitinib and lokivetmab had some good positive effect on skin barrier. And these are the picture of the dogs on day 28. So you can see that the control was still having horrible skin lesion, steroids still having some lesion, cyclosporin so-so, but oclacitinib or lokivetmab were performing better. Okay. So we have probably induced control of the disease with either steroids or oclacitinib or lokivetmab. Now we need to discuss with the client the long term. The long term could be the allergy vaccine. That's a very good option. We need to do allergy tests, of course. We need to do either the intradermal test or the blood test, or even better, both, in case you are afraid that you are missing some from one or the other. It's usually an option that I strongly recommend, because some people don't really like to pill the patient every day or twice daily, and so people like to give an injection. Especially if people learn how to give injection, they can easily do that at home, and it's an option that is safe, effective, and long term. I found that quite often clients will go for it. I mean, the WHO had come up with a number of sentences why immunotherapy is good in men, and we could probably say that that apply also for pets. In dogs, nowadays, we have also the option of the oral allergy vaccine that can be used, for example, in dogs that reacted to the injection, or the advantage that in the same vial we can include molds and pollens, something that is not feasible to do if you are giving the injectable immunotherapy. I mean, the only problem with the allergy vaccine is that you need to do skin or blood test. The owner has to choose the injection or the oral. The oral needs to be given every day, so that's slightly inconvenient. The slow onset of action. And there was a nice paper that review the immunotherapy success. And most of people that said that was not successful is because those clients had not gone long enough. You need to tell them that the allergy vaccine needs to be given at least for 12 months. They cannot expect a full improvement after 1, 3, 6 months. Some dogs may do great after 3 months, and I had some patient that responded beautifully, but some dogs really need 12 months. And when they looked at and follow up these cases, they found that the success rate in dogs that had received the vaccine for 12 months was much higher than people had probably predicted. Okay, next option. What about the mighty Piriton? I really would like, I would have loved to be in a room probably with all of you and see how many people will stand up and agree with me that Piriton is probably the most commonly used antihistamine in veterinary practice. Would you like to know what I think about Piriton? I guess some of you are probably laughing. I hope so. I don't know why. I don't know why the old generation or our previous generation of vets love Piriton. It's still the most popular antihistamine. Anna Pasquale said, I use Atarax indeed. Okay, Atarax is good. And the reason is because Atarax contain hydroxyzine. The problem with Atarax is it's hard to find. So for those people that really like to try an antihistamine, either we get the hydroxyzine from abroad or the cetirizine. Many dogs get a sedative effect. That's the reason why probably they may be slightly better. I mean, these are products that are not licensed. The efficacy is really poor. I rarely use them only when people say, oh, I have hay fever and the antihistamine works. I said, okay, do you want to try? And so I say, yeah, you can try for 3 weeks, for a month. And then eventually they come back and say, oh, yeah, that's not very effective in my patient, in my dog. So I hope from now on you will never use Piriton again. Cyclosporin. Cyclosporin has been a great drug that came on the market probably, I don't know, 25 years ago, I guess, in veterinary medicine. What I found is that many people give up using cyclosporin because dogs have side effects. But I always tell them, give with a meal. Don't bother about what is written on the leaflet, because it's normally recommended 2 hours before or after the meal. No, there have been studies that are published in the literature that show that if you give with a meal, it doesn't cause any side effect, or very rarely. So make sure that it's given with a full meal. And then remember that if you are giving ketoconazole, or you can give ketoconazole if you want to reduce the dose of cyclosporin, because if you give ketoconazole, you can reduce the cyclosporin dosage in half. I'm just checking the time. I think we are okay with the time. And then remember that if you have a dog that has got epilepsy and is on phenobarbital, then the dose of cyclosporin will be limited by the phenobarbital, so you will need to increase the dose. There are so many studies about cyclosporin, but one that is really interesting is the synergistic effect of cyclosporin and essential fatty acids. So basically, if you give essential fatty acids, and we'll briefly touching the EFAS in a minute, they can use a lower dose of cyclosporin. So that's good, because it means reducing the cost for the client. Eventually, some dogs take several weeks to respond. Some dogs may still be vomiting. That's what I would normally recommend: to discontinue, restart at a lower dose, or freeze the capsules, or use metoclopramide or maropitant. And if they have diarrhea, discontinue and restart at a lower dose, or use metronidazole if needed. Very uncommonly, you get dogs that will have papillomatosis or other problem. Honestly, I've rarely seen this. The most common problem I've seen is the gingival hyperplasia. So you get dogs that get mild or very severe, and I wonder why they kept giving cyclosporin to this West for who knows how many years, and why they didn't stop. But then eventually surgery can be done. This was an excellent surgery done, as you can see, before and after, by our soft tissue specialist Dick White a few years ago. And then of course we stopped the cyclosporin and switched to something else. You can give azithromycin. In the States, they even can have the toothpaste formulation of azithromycin in case you are forced to continue with the cyclosporin because perhaps the dog is not responding to anything else. Yes, Aisling is saying that the oral allergy vaccine is apparently been discontinued by one company, but I saw the letter probably last week, but I wonder if other companies have withdrawn it as well or not. So that's something that we will need to find out. You can add short courses of steroid or clasitinib. That's something that has been done because, for example, there was a study that was published 6 years ago where they suggested, you can see at the bottom here, that the concomitant administration of cyclosporin or clasitinib for 3 weeks to beagle was well tolerated, was not associated with an increase of adverse events, and was more helpful than just having cyclosporin alone. You may have heard about tacrolimus. Tacrolimus is a human product. There have been a couple of studies. It's very useful for localized lesion, I don't know, interdigital spaces or lesion on the face. It's very safe. Some dogs may probably resent the application because maybe stinking, but most of the time it's very effective. One of the other products that is also normally recommended for dogs with atopic dermatitis, where you have controlled most of the clinical signs. And so some dogs may require a concurrent application of a spray containing steroids. So very good product, but you don't have to, you need to make sure that the client doesn't spray that every day for years, as this lady has been doing. I gave the product, and I'm sure I told the client to spray once or twice a week, but then eventually she came back after 1 year and said, "No, my dog is starting to lose the hair. It's probably got something else." I said, "No, that's the reason why, because you are spraying the hydrocortisone on the chest, on the side of the body. That's the reason why you are causing this iatrogenic hyperadrenocorticism." There are so many topical steroids that can be used. Human, veterinary products, so the ones that are available in veterinary medicine are the two that I showed you in the previous slides. Essential fatty acids. I really love essential fatty acids. I think they are great. I mean, for us, for our patient, we need them because unfortunately, sometimes we can't get enough through the diet. They will modulate the inflammatory response. The next slides may be probably too much at this time of the day, so I'm just going to skip, but then eventually you can see again this video if you want, in case you are interested in knowing more about the cascade which occur in the body following the arachidonic acid metabolism in both keratinocytes and mast cells, and all the type of cytokines that are produced, and why the omega-3 and the omega-6 are helpful, because they lead to production of cytokines that are less inflammatory than the one that are normally produced by the arachidonic acid. Where do we get the essential fatty acids? Fortunately, there are plenty in the borage plant. I don't know if you have seen any of these in your garden or in your allotment, but of course you can buy the borage oil in a health shop, or you can get the evening primrose oil, or you can get omega-6 through the fish, or buy capsules or liquid formulation of omega-6. So there are different concentration of omega-6 in different type of vegetable oil. Who knows how much sunflower we can get in the future after this recent war. But fortunately, we can use evening primrose oil, which is currently available and is very good. Also not too expensive, and this you can see has got the highest concentration of linoleic acid. I mean, I love borage oil. It's one of my favorite, and even the plant. I don't know if you have ever eaten as a vegetables, but it's great. The good things about essential fatty acids, as I mentioned before, is that can be associated to antihistamine, corticosteroid, cyclosporin, because there are synergistic effects. And there are a number of studies that have demonstrated that. I'm going to skip through these couple of slides because you can always go back and look at the reference if you're interested. The problem is how much omega-6, omega-3 we need to give. Well, what is definitely important is to remember that you need high doses of essential fatty acids to be able to achieve enough concentration in the body at the skin level to help protecting or making a difference in patients with atopic dermatitis. So that's something that needs to be done. Now, almost down to our list, the diet. Normally, when I start treatment in patients with atopic dermatitis, I still keep on a very good diet, because I say, look, we need to standardize the lifestyle of this patient. We cannot start on whatever we decide to start and then go back to a commercial diet, because if the dog is not responding, then I will not know if there is a food component, or perhaps is not responding to the whatever medication I've decided to use. So that's the reason why I like to keep either on a hydrolyzed diet or on a vegetarian diet, one of them, whichever you like. Okay, what else? That was also one of my questions in the question that you were emailed. What else can be done? Well, now I think you have plenty of options available, but The future is on us, because fortunately there are people out there in the States that are working on new product, anti-canine interleukin-4, so something that is called dupilumab. All these interesting, funny name. But even more, if you look at the website of this company, they are coming out with new product for interleukin-31 antibodies for atopic dermatitis in dogs. And this one is even for inflammatory bowel disease in dogs. That will be very interesting. And the interleukin-4. So probably in a few years, you can see they're almost close to the end for some of them. Probably, who knows, in another couple of years, we will have many more weapons on our pharmacy to control atopic dermatitis. But something that needs to be remembered is that atopic dermatitis can be prevented. And now, are you those guys that really work with breeders and help them to prevent condition? Or probably you just let breeder to keep breeding from affected dogs so you can be in business and the future generation can be more in business treating dogs with all sorts of genetic disease? Well, that's a big question that we need to ask ourselves. Are we going to stop or not? Definitely we want to stop, because there is no point to have pets to suffer from this condition, and it's your duty to inform the breeder, the owner, not to breed from affected dogs. There have been a number of studies like this one in West Island White Terrier that show about the genetic of atopic dermatitis, so definitely it's genetic. And this one was the study that I mentioned you before from Stephen Shaw, that the Labrador, the chocolate Labrador, and the lifestyle of dogs definitely play an important role. So, in conclusion, it's a multifactorial disease. There are genetic and environmental factors. The skin barrier needs to be restored. The interleukin-31 is going to play a major role. And we know also about other interleukin, and hopefully the interleukin-4 antibodies that will be developed will be helpful to block the interleukin-4. So I always tell the client, don't think about that one product is going to fully control the allergy in your dog. No, we may need probably a combination of product. This combination may change over time during the different season of the year while the dog is aging, because of course there may be different type of needs. Okay, now make sure that you are confident with all the options, and so you can easily tell the client the pros and cons of all these options, because clients need to be educated, they need to be informed, otherwise they will go on the web and they will ask Dr. Google what to do. So you need to prevent this and tell them, showing knowledge, being professional, that you know how to approach these cases. Don't be one of those vets that will try for 2 weeks APOQUEL, and then will try 2 injections of Cytopoint, and then you will say, okay, the next option will be CICLOSPORIN, and then if it doesn't work, then we'll try the allergy vaccine, and changing every 2 or 3 weeks product. Okay, now it's time to go back to our hypothetical cases. So, the question that I wanted you to think about was this about the chocolate Labrador. Well, we know that he's unlucky because it's chocolate, but what are you going to use now? One of these, something else? Well, you need to think that at this age, you need to wonder, okay, has this dog developed the problem at 10 years of age, or has been itchy and having a skin problem for the past 9 years? So there is a lot to probably to discuss about this case. And I hope that from this lecture, you have learned how to work out these cases. And so then you can make a very good decision about the options that are out there and the best one for this patient. But let's go back to the patient that I told you before. 7-year-old German Shepherd. Now it's got MRSP and MRSA. So of course you don't want to use APOQUEL. You don't want to use steroids. You don't want to use cyclosporin. So what are you going to use? Well, that will be probably the best option to use now that this patient needs to be treated for this nasty infection, because who knows how long it's going to take, months perhaps. A combination of topical therapy, maybe systemic antibiotic. So you need to use something that will not mess up the immune response in this patient. What about the Westie, 12 years old with a long history of atopic dermatitis, but now he's got cutaneous lymphoma? Which one are you going to choose in addition of probably discussing the option with the client for treating lymphoma? Are you going to use APOQUEL, steroid, cytopoint? Well, here again, you don't want to use APOQUEL in this patient. You may want to use steroids probably. That's possible. Because steroids are also part of the protocol of cutaneous lymphoma. So that's an option, or perhaps even a combination of steroid and cytopoint. I mean, you may probably want to ask advice, probably an oncologist or one of the dermatologists, but that's what I normally do. And then what about that middle-aged English setter? It's doing great on cyclosporin, but it's the time of the year that needs the annual booster. So you have to stop cyclosporin for 2 weeks before and after. So what are you going to use? APOQUEL, steroid, cytopoint? Well, here again, I will probably say cytopoint will be the best option. I mean, the dog could probably have a small dose of steroids, but cytopoint would be probably my top choice in this case. And now what about that nice, friendly English bulldog with the long history of atopic dermatitis, which has now got horrible interdigital furunculosis, hyperproliferation of the skin, this excessive piece of pads that are growing underneath, between the pads, between the toes? What are you going to do? What are you going to use? Probably the dog needs systemic antibiotic and topical therapy, because those interdigital furunculosis usually harbor all sorts of bugs. But which will be the best therapy in this case? APOQUEL, steroid, cytopoint? Well, this time I prefer steroids. Steroids topically and systemically, that will give quick relief, reduce the swelling, the inflammation, as long as needed. And then perhaps we can discuss with the client's other option. What about that Cocker Spaniel with the long history of bilateral otitis and atopic dermatitis? Okay, if the client agree, because you suspect otitis media, go for a scan, ear flush, and while he's under anesthesia, you plan the best topical therapy based on the cytology and or the culture, but then it's the time to decide, okay, what's the best therapy for this patient? So what are you going to do? Well, honestly, I don't try APOQUEL. I may try steroids because many clients cannot afford other medication and they work great. Cytopoint is not very helpful in these cases. Allergy vaccine, maybe long term, but now what they need is cyclosporin. So either steroid or cyclosporin, and then once the inflammation, the stenosis, it's resolved, then we could probably, and we should consider something safer like the allergy vaccine. What about the puppy? The puppy with, well, almost 1-year-old Jack Russell. We know that he's probably unlikely to be food allergic, doesn't have any parasites. So what are we going to use in this dog? Can we use APOQUEL? Well, but he's less than 1 year of age. Can we use steroids? Well, we could if the owner doesn't have money. Or I would suggest probably cytopoint will be the best choice for this patient at this age. Cyclosporin probably not yet, although it's not going to be too expensive for such a young dog. But then the allergy vaccine will be definitely the best option long term, because this is a patient that is only 9 months old. We already know that he's got atopic dermatitis and needs probably medication, who knows, for another 10, 15 years. So long term probably may do well on the allergy vaccine. Well, I see that all of you are still there. I'm very happy. I hope that you enjoyed this webinar. Was helpful, informative, and probably tomorrow morning when you are back to clinic, you can better manage this atopic patient. And I see Lydia as well. So thank you for listening. And if you have any question, I'll be happy to answer either in the chat box, but I see, Lydia, that there are some in the question and answer box.
Yeah, we have lots of questions. Thanks,
Should
Rosario.
I read the question?
Yeah, if you're happy to read them out and answer them, that'd be brilliant. I mean, I'm very curious to try borage after your talk.
Okay, the first question was from Ruth. She said, are you comfortable with a dog being on APOQUEL long term if it keeps the dog comfortable from pruritus? Yes, although I would probably recommend, that's my personal view, I would probably recommend blood tests done routinely every 6 or 12 months, urine analysis. But I do have dogs that are on long-term APOQUEL and they are doing great. One more question from Ruth. Which essential fatty acid product are you I normally use? Well, the one that are veterinary licensed, which contain omega-6 and omega-3, and there are 3 or 4 on the market. So I don't really need to mention the brand name, but the ones that are on the market are very good. Is that true that, Justin asked, is that true that dogs process fish oils better than vegetables? Well, the difference is between fish oil and flaxseed oil. They will metabolize better fish oil than flaxseed oil. Both of them are omega-3, but omega-6 is something that dogs still need and will be helpful to improve the skin and coat quality. I am a fan of salmon oil, but it's become difficult when you have to put a dog on a hydrolyzed diet. Yes, Justin, I agree with you. And that's the reason why I often either do not use anything or go for flaxseed oil, which at the end of the day, probably something is still absorbed. I feel like I ended up advising many clients to put their pretty dog on a food trial after appropriate flea and ectoparasite treatment. Is this a correct thing to be doing? Yes, you need to rule out parasites, and if you don't see parasites, start them anyway on a strict ectoparasite control. Should I be suggesting a derm diet for those that don't pursue a true food trial or have seasonal pruritus? Well, having them on a prescription diet, a hydrolyzed diet, or a vegetarian diet for a period of 2-3 months will be ideal. I found that many clients say that, well, it's only probably 5-10 pounds more per month, of course, based on the dog size, than probably a very good commercial diet. Of course, if they are on a supermarket diet, it's going to be probably double the price. But I found that many clients, honestly, are not concerned about the cost or probably the type of clientele that we see. But if they can afford to buy a hydrolyzed or vegetarian diet, that would be great. Next question from Anonymous. Hopefully it's not one of those hackers. Anonymous said, how do you know allergy vaccine has worked if still on other antipruritic? Do you try to stop them? Yes, I will normally stop the whatever medication they are on every 3 months and see if dog is doing great. And if he's doing very well, means that doesn't need any more the medication and the vaccine is working. Aria said, what is the significance of IgE and IgA in the food allergy blood panel? How do I use it to choose a novel protein if the clients want home cooked diet? Well, I would say don't even look at them. Don't even bother to do blood tests for food allergy, but it's just a waste of time. Without even mentioning those clients that come and say, oh, I send a cheek swab, or I send some hair plugs to a lab that I found on internet, and I tell the client, okay, how much did you spend? 50, 100 pounds. I said, okay, you just wasted your money. And the client say, oh my God. Anyway, no, don't look at them. If you want to use a novel protein, try to find out what the dog has been eating or the cat, and then try to go for something really new. The problem is what is new. Even horse meat was in dog food and in human food a few years ago. You remember the scandal, I don't know, 6-7 years
Findus
ago.
lasagnas, yeah.
Yeah. So how do we know that something new? Sometimes I say, okay, shark or perhaps a skate. Skate is definitely more easy to find, but not very cheap. As far as meat, rabbit will be definitely a new type of meat, but not many people are really willing to give rabbit to their dogs because they feel sorry for bunnies. But I mean, you can buy from Germany on the web pet food which contain rabbit and horse, but most of the time I ended up recommending a hydrolyzed or a vegetarian diet. I mean, even insect diet could be good. Although some of the insect diet on the market contain soybean, and unfortunately soybean is a common cause of allergy in dogs, so that's something difficult. Sorry. Callum is asking, what diets would you recommend for diet trials? Normally I recommend, okay, exactly the one that I just put on the picture in my presentation. Hill's Derm Complete is also good, but keep in mind that the Derm Complete, it's egg-based. So you need to make sure that the dog is not allergic to egg or chicken, because egg and chicken can cross-react. And many people don't remember that turkey and chicken cross-react. And I've seen so many times people saying, oh, I've switched from chicken to turkey. No, that's bad, because chicken and turkey will cross-react. Anonymous again, Anonymous said, after your diet trial and challenge, do you ever try to change the fixed formula skincare? Yes. After a diet trial, if the diet trial has not made any difference, they can even go back to a commercial diet, assuming that they are now doing very well on whatever we are doing. When you change the diet, it will be interesting, because if they become suddenly itchy, means that probably, or they flare up with the ears, means that probably the change of the diet is a problem and perhaps is contributing. And then where is gone the mouse?
We've had quite a few repeating questions, Rosario, about the English Bulldog and the steroids. A few questions asking, why would you choose that as your first line with the interdigital furunculosis? And how long would you keep the Bulldog on steroids for in that case?
Because English Bulldog are a nightmare, and the owners of English Bulldog are even worse than other clients. I don't know why. And I found that steroids make everyone happy, and then honestly makes a big difference. You will not get such a quick response, good response, without steroids, I'm afraid. Yeah. I normally don't like steroids, but this time they are my top choice for the English Bulldog. Quick scroll through the other question. Grain-free diet? No, because there are only two breeds that probably have grain problem, like, I don't know, the Irish Setter and the Border Terrier. So don't bother about people that believe in grain allergies. Anonymous again. Why you don't want to use APOQUEL for dogs? You need to be off cyclosporin for a vaccine. Does APOQUEL affect healing from surgery? Oh, these are very good questions, Anonymous. I think we need probably to double check that, because I'm not 100% sure if APOQUEL will affect the healing from surgery, and if it's ideal when you stop cyclosporin. Madalena asked, Cytopoint still working after the second dose? No, that's not true. May get slightly better, but Cytopoint, if works, I found that works within a few hours, 24 hours. How often to advise a bath for a dog or a cat? That's such a complicated answer, because it depends from the skin, if there is seborrhea, or if it's just scaling, or if it's a normal skin and coat. Rob asked if an Atopy dog is negative on blood testing, will skin testing be more sensitive? Sometimes I found that they don't match, and most of the time I actually do both if clients can afford to pay. One more. Omega-3 supplements from humans, yes, good quality product are very good. Is Royal Canin sensitive control good as hypoallergenic? No, I will not go for the hypoallergenic. I will go for the anallergenic.
Brilliant.
Back to the chart.
I've covered a few of those. There was one if a middle-aged Labrador is on Artraveterin, cyclosporin, cytopoint, and still requires occasional steroids, what would you use to control the pruritus when he needs to be off cyclosporin before and after the vaccine?
Well, if this dog is on so many products, I wonder, has this dog got just atopic dermatitis or there is something else? Has food allergy been ruled out? Because I rarely see patients that would need the vaccine. Did you say APOQUEL and cyclosporin and sometimes even steroids?
It was a list. So Artraveterin, cyclosporin, cytopoint, and occasional steroids.
It sounds a lot of drug. Either this dog is very unlucky or probably the dog may have a food allergy that perhaps it's worth investigating. Well, something needs to be done because the dog needs the annual booster. So of course needs to stop. I would probably keep on cytopoint and probably use steroids and stop the APOQUEL if you need to stop the cyclosporin.
Brilliant. And I think one last question is, can EFAs interfere with diet trial? And then I think everything else you've kind of covered in your other answers.
Sorry, tell me again. I was trying to remove the laser point.
Can EFAs interfere with diet trial?
Yes, if you're giving fish oil, yes. If you're giving omega-6, which is vegetable, not. And if you really want to give omega-3, you better switch to flaxseed oil.
Brilliant, thank you. I think that we've got lots of questions still coming in. I do apologise if we haven't been able to answer all of them, but I know there's lots of kind of specific cases. If you do have any specific cases that you'd like to speak to Rosario about, then he is available for VVS advice calls and does a fantastic job. We've had wonderful feedback from everyone that has been lucky enough to work with him so far. And I wanted to thank you very much, Rosario, for a brilliant webinar, really informative. I know it's a tricky subject and it's always difficult to manage in practice. So thank you for making it so interesting and enlightening, and hopefully with some good takeaway points for everyone. But thank you all for coming tonight. Thank you, Rosario, and we hope to work with you all soon.
Thank you, Lydia. Thank you for offering me this opportunity to present this topic that I really love. Have a good night, everyone. Bye.
Good night. Thank you.
Good night.
Bye.
Bye-bye.